everyone. Welcome to MS Radiology. My name is Mathuri. I'm a consultant radiologist in the UK. For this video, what I'd like to talk about is CT scan protocol, and I'm going to talk about the main protocols that we use when we're scanning inpatients and patients in the emergency department. So I'd like to start at the head and work my way down. So first of all, in terms of imaging of the head, most questions that we need to answer is answered by a non-contrast CT head. So common things that we look for in the emergency setting would be looking for any evidence of intracranial bleed or hydrocephalus, or any evidence of stroke or contraindications of stroke. All of this is answered by a non-contrast CT head. And even in the circumstances that we need to do a contrast head, what I would suggest is that you always have a non-contrast head, and we do the contrast scan subsequent to this. The reason being that in the case of venous sinus thrombosis, for instance, if we don't do a non-contrast scan, we may miss potential other pathologies that may mimic the signs and symptoms of venous sinus thrombosis. So moving on to the type of contrast scans that we can do in imaging the head, we can do CT angiograms, which is essentially imaging the intracranial arteries, and this can be used to look for any evidence of a thrombus in the setting of a stroke, or we can look for any evidence of vascular malformations, or common scenario is to look for aneurysm in the context of non-traumatic subarachnoid hemorrhage. As I've alluded to earlier, we can use contrast to determine if there's a venous sinus thrombosis. And the important thing to remember in this particular clinical scenario is always do a non-contrast head as well as a venogram, which will look for venous sinus thrombosis. So we've talked about a plain head, CT intracranial angiogram, and venogram. The other type of imaging that we can use contrast for in the head is a post-contrast head, where we image it a lot later than we would for an angiogram or a venogram. And this is helpful to evaluate for tumors or abscesses. Now, one of the points that I want to make is that most of the time, when you have a brain tumor, most people end up having an MR. So, in my opinion, that this negates the need for any post-contrast head imaging. However, remember that in certain patient groups who may not be able to tolerate MR because they may have claustrophobia or have contraindications to having an MRI, in which case we can use a post-contrast head. And remember, at this moment in time, a CT is much more easily accessible than MRI. So I think a post-contrast head still has a role. Now I'd like to move on to the chest. So With regards to the chest, the commonest sort of chest type of imaging that we do is a CTPA, CT pulmonary angiograms, and the main aim of this study is to evaluate for pulmonary emboli. Therefore, we're looking for maximum or good enhancement of the pulmonary arteries. You can use slightly different techniques to achieve this, and each trust for CTPAs as well as other CTs have sort of local protocols, which I suggest that you familiarize yourself with when you start working at the chest in the trust. So for a CTPA, you can use a test bolus technique. In this particular case, what we do is we give a small volume of contrast with a region of interest, and we calculate the time it takes to have peak enhancement of the pulmonary artery, and we use that to time the scan. Or you can use a technique, a bolus tracking, where you place a region of interest and the scan is triggered when you've got peak enhancement. The other type of imaging that you can have is arterial CTs of the chest. Commonly, we use that for staging studies, or the initial study in staging lung cancer, for instance. The other type of imaging of the test that you have is a angiogram, and typically that's used to evaluate for aortic dissections. Now, the traditional teaching is that you do a plain chest, which is helpful to evaluate for an intramural hematoma, which may be masked when you give contrast. And in the contrast phase, you've got maximal contrast in the aorta to evaluate for a dissection or any other aortic pathology. The important thing about this test is to avoid motion artifact, particularly of the aortic root, as motion artifact in the aortic root can mimic a dissection. So one of the techniques that we can use to help with this is ECG gating. So ECG gating can help eliminate motion artifact in the aortic root. Traditionally, with aortograms, you imaged from the aortic root all the way down to the bifurcation of the aorta. BJR has published a very interesting paper which suggests that for some patients we can actually stop the contrast imaging at the level of the diaphragm, and in thus reduce the dose for the patient, as well as, and this can reduce the radiation dose for the patient. So what this paper suggests is that if a patient has only one high risk feature, you can stop at the diaphragm. So high risk features can come from personal history, such as Marfan syndrome or connective tissue disorder, or from the clinical symptoms itself. So sharp acute onset sort of tearing chest pain, or clinical findings such as differential in the blood pressure or the patient is hypertensive. I've linked the paper for those of you who are interested in having a look at that. Okay, so the final type of contrast type of chest imaging that I want to talk about is a pleural face chest, which we can use for staging cancers or in the context of uh, mesothelioma or for evaluating for empyema. And the timing of this is the same as a portal venous abdo-pelvis, which I'll talk about a little bit later. Finally, we have the non-contrast chest. It, in the past, we used to do HRCT chests, or clinicians used to request HRCT chests, I should say, where we have fine cut images of the lungs to evaluate interstitial lung disease. In the modern era, we've got spiral CTs, which can be used to reconstruct very thin slices of the lungs. So nowadays, any sort of plain chest imaging is essentially a HRCT chest. The other thing that I wanted to mention was that commonly I get called and a patient's had a CTPA and an abdomen and pelvis where they've diagnosed a cancer, and they say they'd like a imaging of the chest to complete the staging. So to evaluate for lung metastasis, any type of chest imaging will do, whether it be plain or any post-contrast imaging will do. So if you've got the lungs that's imaged, that suffices for your staging, and there's no need to repeat the chest imaging and add to the patient's radiation dose. Next, I'd like to move on to the abdomen and pelvis. By far in the emergency setting, the commonest type of imaging of the abdomen and pelvis that we do is the portovenous phase, which is about 60 to 80 seconds. As I mentioned previously, different trusts will have a slightly variable protocol for this, and I suggest you stick to your local trust protocol. The reason why the portovenous imaging is so good is that most of the abdominal viscera is best as a good portovenous supply, such as the liver, the gut, has a portovenous supply. So the portovenous phase is the best phase to evaluate this. Now, the other type of imaging that you can use for the abdomen and pelvis is the aortogram when you're evaluating for aneurysm or aneurysmal rupture. And then what the next type of imaging that we have is what I call the bleeding protocols. So when the patients come in and they have PR bleeding, for instance, or evidence of upper GI bleed, and you want to find the source of the active bleed. So for that, we use plain, arterial, and portovenous or slightly delayed 2 minutes imaging of the abdomen and pelvis. So that is sort of what we call a triple phase study. And the significance of a triple phase study is that it's the triple the dose for the patient. So it's like a patient having 3 CT scans of the abdomen and pelvis. So that's worth bearing in mind. So why do we do this triple phase? So the plane is helpful because with, to look for bleed, we're looking for contrast out of vessels where it shouldn't be, and contrast is hyperdense. So if there's hyperdensity within the abdomen and pelvis, such as areas of calcification, you don't want to mistake that for areas of active bleeding, and that's the main purpose of doing the non-contrast study. The arterial phase helps with the anatomy and a potential a source of bleeding. And then obviously the delayed phase is very helpful if you've got a slow uh, venous ooze, for instance. You will see pooling uh, of the contrast in the area where the bleed is coming from. So the arterial phase, you're looking for extravasation of contrast, and in the venous phase, you see that blood pour further to help identify the source of the bleeding. The important thing to remember is that you need to have the patient, or the patient needs to be actively bleeding and bleeding at a certain rate to identify the source of bleeding. So the fact that if we say in our imaging we haven't identified the source of the bleed, it could be because that patient bleed is not fast enough to be detected, or they're not bleeding at a rate that can be detected by CT angiography. Now, I'd like to talk about staging scans for cancer. More and more, we're attempting to do staging scans for cancer in the emergency setting. So this does vary from trust to trust. For some trusts, the typical staging kind of protocol would be an arterial chest and a portovenous abdomen and pelvis, or the other type of staging scan that you can have is a sort of a 70-second chest, abdomen, and pelvis. The advantage of this is that you can sort of scan the patient in one go. In our trust, we do a majority of our staging scans at about 70 seconds. One of the things to kind of bear in mind is that for hypervascular tumors, by that I mean melanoma or renal cell carcinomas, remember that the metastases for these are arterially enhancing. So when you're staging these tumors, we need to do arterial phase imaging. So in our trust, we do what we call the staging chest, abdomen, and pelvis, which is about 70 seconds, and we also do an arterial phase abdomen to evaluate for the arterial metastasis that you get in melanoma, renal cell carcinomas. Now I'd like to move on to the trauma scan. And the trauma scan, or the protocol that we use, is something called a Cambastian. This is called Cambastian protocol because it was developed in the military to get a patient through the scan quickly, because this is particularly important in a patient who is hemodynamically unstable. So we use a biphasic protocol where we have imaging in the arterial system as well as the portovenous system. So we do a plain head, and we do imaging of the neck to evaluate the C-spine, and the chest, abdomen, and pelvis is done in this biphasic protocol. Ideally, if if you can supervise or you've got the resources to supervise trauma scans, I would very much advise this, because that allows us the opportunity to add further imaging if we need to. So, for example, if you're worried about urothelial injury, you might want to do a further delayed phase, 5-10 minutes to evaluate for that. Or if you're worried about a sort of a bleed or a source of active bleeding, or like a slow venous bleed, then you might want to do a slightly delayed phase to see if there's pooling. So I think if you can supervise your trauma scans, that is very helpful, so that you can add the so that you can add the extra phases if you need it. Now, the most important thing that I say to all my clinicians, all my medical students, is don't worry about phases of, or what particular CT or what particular phases you need to request. The thing that I would like to know is the focused clinical question. And if you give me a focused clinical question, I can choose the most appropriate phase to answer that clinical question. So that's why I encourage everyone to give pertinent, succinct clinical information in your request. Not only does it help us request or do the right phase for the study, it is also very helpful when we come to report the scan. So, the clinical request, from my point of view, is very much a communication between the radiologist and the referrer. And it is very, very important to ensure that the patient gets the right study at the right time. And what I would encourage everybody, all clinicians, to do is that if you're not particularly sure what particular study to request, just discuss that with the radiologist. You may have certain complex patients where a discussion is warranted. So that's all I have to say. Thank you very much for listening.